a lot of our patients have already reached that bottom of the pit, right? They have nowhere else to go. They still have to go to work. They might be an accountant, a teacher, a plumber, and you can't just say to them, look, don't go to work. We want sound biomechanics that promote stable joint movement, because stability of a joint is king. Nothing can beat stability. That is movement dysfunction. If you have difficulty doing that, then you have movement dysfunction related to your shoulder girdle and probably your cervicothoracic spine as well. All of the secondary symptoms that you're feeling as a consequence of your movement dysfunction are related to the poor health of the joint and periarticular soft tissues. Up to my shoulders, and from that position I can do an overhead squat. So without functional movement proficiency, you can't do that. And even though that may seem like it's a functional demand way in excess of the functional capacity that most people require, little old grandma still needs to be able to understand the biomechanical fundamental principles that are associated with bending her spine. All right, good evening. Hope you're well, guys. Just thought I'd do another little video focusing on the concept of movement dysfunction. If you've seen some of the posts that I put on LinkedIn and some other locations, you'll have a bit of an idea now that I really conceptualize movement dysfunction as a disease. It's a functional disease. It's ubiquitous. It's 90% prevalent in modern society. We've done the research. We've shown that that people, living and working and engaging in their normal lifestyle activities in this modern society that we have corrupts movement, and in a way our modern society behaves as a little bit of a domestic cage on our biomechanical movement proficiency, and that domestic cage limits our musculoskeletal movement potential. And when we become afflicted with musculoskeletal pain-related symptoms, the industry and the sort of conventional teaching is to control those symptoms and to try to make people fitter, stronger, more agile, more stretchy, and in relation to the spine, try to improve their core strength. Okay, the core strength muscles, our abdominals, our erector spinae muscles, our pelvic floor, our diaphragm. All of that's fantastic, but the point that I'm really trying to make is that none of those elements of rehabilitation improve functional movement proficiency. And I will define functional movement. Every term that we use has very clear definitions, and I think it's pretty clear in terms of movement proficiency that we want sound biomechanics that promote stable joint movement, because stability of a joint is king. Nothing can beat stability. If you have a stable joint, then you don't have accelerated joint deterioration. You have natural joint aging, which is pain-free. Okay, degeneration is not painful. That's by definition. If it is painful, then you are afflicted with degeneritis, and that's pathological. And you are therefore, by definition, breaking the rules of movement proficiency, or you are engaging in functional capacity activities that or functional demands in your life that exceed your functional capacity, because stability is interrelated to capacity. Okay, if I have an unstable cervical spine teardrop fracture, then I can create stability in that person's neck by putting them on a spine board and immobilizing their neck in a collar. I have immediately created stability in what is a structurally unstable neck. So stability is very much linked to capacity. So just because an injured worker with functional instability, i.e. back pain, say secondary to a annular tear of his disc or a facet arthritis, if they have pain associated with that structure, that is functional instability. And I can improve on their pain situation by decreasing the demands on them and saying, okay, well, don't go to work, just rest at home. Yeah, I've immediately altered the stability demand interrelationship and they're okay. But unless I actually truly restore their joint stability, they are going to be stuck in that situation where they have to continuously reduce lifestyle demands in order to keep stability in check. The moment they try to go back to work or do a graduated return to work program, oh, I'm sore again, and the cycle continues. So we've always got to pursue stability, and stability comes from coordinated movement, and that's been well described by Punjabi in the 90s in his model of stability, having three elements: the passive elements, the active elements, and the neural control elements. And the neural control is the most important thing, because I just earlier talked about modern society corrupting neural control, modern society corrupting our movement proficiency. Our active and passive elements just go along with the ride and have a lot more relationship, or the active and passive elements have a lot more association with your functional capacity. Okay, I would rather you be a really weak person moving well than a really strong person with very powerful active and passive elements moving poorly. Okay, so the strong person moving poorly is going to have joint pain. The weak person moving well will be happy as happy as Larry, because they don't have joint pain, but they may not be able to do very much. Okay, so that's your capacity interrelationship there, baked into Punjabi's stability model of the lumbar motion segments. So just so that people can understand a little bit about all of that mumbo jumbo, and that's part of our movement theory course that we do here, and we've taught many clinicians, we've taught many physical therapists movement theory, and once you actually engage in it and sort of open your eyes to movement dysfunction, movement proficiency, capacity demand, structure function interrelationships, and have a really good framework of understanding pain in this paradigm. There are obviously multiple frameworks, but the framework that we utilise is very, very clinically applicable. All the jigsaw puzzle pieces kind of fall into place, and treating musculoskeletal pain, in particular spine pain, becomes really quite simple. It becomes complex if people present 20 years down the track of having, chronic pain. Of course there's complexities, but that's only because it wasn't addressed in the simple manner that it should have been, 10, 20 years earlier. So just so, back to the what we've got here, I just want to suggest for anyone who's interested, just to say, look, do you have movement dysfunction? Just get a broomstick out of your cupboard, okay, stock standard broomstick, and just do a couple of things and just ask yourself what it feels like to do these couple of little tests. Just grab the broomstick in front of you and just do what's called a passover. Okay, just do a passover. Roll that broomstick over your head to side on. Okay, now if you can do that, that's fabulous. You might be super stable in the shoulder joints. If you're having difficulty doing that, you might say, oh, that's just because I've got tight shoulders. I've just got tight muscles, or I've got some rotator cuff issues, or bursitis issues, or tendonitis. That, you may be surprised, is movement dysfunction related to your shoulder girdle causing those tight, pinchy, sharp, limited range of motion symptoms. Okay, that is movement dysfunction. If you have difficulty doing that, then you have movement dysfunction related to your shoulder girdle and probably your cervicothoracic spine as well. The all of the secondary symptoms that you're feeling as a consequence of your movement dysfunction are related to the poor health of the joint and periarticular soft tissues. So we can see people moving in life, and obviously here at the rehab centre, we can see people from across the room moving and identify poor movement proficiency. And obviously we have the skills to then correct that. So don't think that simply because you can't do this, that can't be restored, okay? If you get good movement therapy, then you start to use the muscles in a coordinated way. Of course, we would have to regress your movements initially. We use the term regression to progression. We would regress the movements initially, but those regressions then allow the development of coordination, which then in turn have an effect on the active and passive elements of your shoulder girdle, which then in turn, lo and behold, several months later, I ask you to do the same thing, and oh my God, you can simply do a Passover without any grimacing, without any discomfort whatsoever, simply because we retrained your movement proficiency. Okay, if you had no problems doing the Passover, just try to do this for me. So raise the broomstick above your head, and this is called an overhead squat, okay? So you've got the broomstick above your head, you've got your feet flat on the ground, and I just want to see and comment below if you can quite comfortably do an overhead squat, okay? I don't want to see you doing this kind of stuff. I don't want to see that, okay? That is compensatory attempts to perform the movement in a dysfunctional way because you can't perform it in a biomechanically stable way. There is no way that this movement has the functional capacity of this movement, okay? If I try to get something heavier, which I will in a second, and do the movement like that, the functional capacity is 1,000,000 times less than if I did the movement like that, okay? So text me, tell me what it feels like when you get a simple broomstick about arm's length apart, put it above your head, just do a simple squat like that, and just identify whether you are suffering from movement dysfunction. And of course, that is the beginnings of your accelerated structural changes to all parts of your body that are associated with that movement. And in fact, your hips, your knees, your ankles, your lumbar spine, your cervicothoracic spine, your shoulders are all necessarily in good working order to be able to perform a very simple overhead squat with a light broomstick. And one of the characteristics of functional movements, just one of the characteristics, there's many, is that a functional movement has the ability to move the largest loads, the longest distance, the quickest. Okay, so that's one of the characteristics. So, of course, if we have proficient functional movement, I can then go from a 500 gram broomstick to a 20 kilogram barbell. This is 20 kilograms. And if I move well and proficiently, I can do the movement in a very powerful manner. Okay? And those are some of the principles that guide functional movement therapy. Okay? I'm bending over, I'm picking up loads. This is a 10 kilogram bumper. I'm moving my body doing these tasks. I want to move my body well. And we talked about this in the previous video. We talked about the simple deadlift. Okay, that's a very simple, one of the most fundamental movements of the human body, and 90% of people don't do it well. When we are doing simple tasks like brushing our teeth, we're effectively doing a deadlift, okay? It's a very powerful movement because it can then lead to me getting 20 kilograms up to my shoulders, okay? It's a powerful movement using some of the same biomechanical principles. I can get the 40 kilogram barbell and plates up to my shoulders, and from that position I can do an overhead squat. So without functional movement proficiency, you can't do that. And even though that may seem like it's a functional demand way in excess of the functional capacity that most people require, little old grandma still needs to be able to understand the biomechanical fundamental principles that are associated with bending her spine, because we have decided to become bipedal creatures. We went from quadrupedal, which would have had us a lot of the time in a functional movement position, driving through the posterior kinetic chain, maintaining hip-centric rotation, maintaining a neutral spine position with very, very powerful and functional and healthy multifidus muscles, which maintain intersegmental stability. We decided to stand upright. We decided to stand upright and do things because it gave us an evolutionary advantage. Now, in so doing, it actually made our lumbar spine inherently unstable, okay? We have our lumbar spine, 5 vertebrae. We have a center of mass above the lumbar spine, and we have a center of mass below the lumbar spine. That's an inherently unstable structure that we accepted that susceptibility for the evolutionary advantages of height and seeing over the horizon, let's say, if you're an evolutionary biologist. But in so doing, we started to increase our spine's lumbar, we started to increase our lumbar spine susceptibility to movement dysfunction. And when you throw in modern society on top of that, it's like, you know, we lined up the crosshairs and modern society pulled the trigger on our lumbar spine, and hence now we have back pain as one of the leading causes of disability on the planet. We need to bring back into our musculoskeletal system some of those movement principles that our ancient ancestors would have maintained during their normal daily life. So resting, this is another test you can do. Can you rest in a nice comfortable position with proficiency, or are you not able to do that? Your feet want to be flat on the ground. The workplace health and safety lifting guidelines are commonly described as this. This is very dysfunctional. This is dysfunctional because we're deactivating the posterior kinetic chain. We're loading the knees. We're pretty much just balancing. We've switched off our multifidus, and that is not a functional movement. I would not ever try to lift something like that. And I don't know why workplace health and safety guidelines have this as it hurts me just demonstrating that. I don't know why workplace health and safety guidelines would have those type of movement pictures and infographics talking about that as a safe biomechanical way to lift things. It's terrible. So try this as well. So I've already showed you the broomstick maneuver. Try this. Can you do a nice squat with your spine in neutral position and your feet flat on the ground, and be able to pick up a 5-cent coin off the carpet, okay? If you can't, then I'm telling you, you've got movement dysfunction. And that's okay, but that is going to limit your capacity, because you're only going to be able to maintain stability by reducing demands. Remember we talked about the stability-demand interrelationship, the broken neck. Yes, okay, we'll lie flat on a spine board. So you might not be able to do that. You might be only able to go to here. Oh, and now if I try to go any deeper, I'm rounding my back and I'm coming forward and my knees are caving in, you know, like a Gumby. You know, like that's going to be your biomechanical technique to get something off of the ground. And of course, that then is very dysfunctional and will drive accelerated deterioration of your joints, and it will limit your capacity. And if you want to have limited capacity, that's fine. But that's the only way you're going to be able to circumvent your inherent susceptibility to instability, okay? But a lot of our patients have already reached that bottom of the pit, right? They have nowhere else to go. They still have to go to work. They might be an accountant, a teacher, a plumber, and you can't just say to them, look, don't go to work, because they need to earn a living, right? And so what are they forced to do? They're forced to take opioids and try to suppress the pain so that they can still, you know, maintain a living. But that is not an effective long-term solution for them. The clear, simple, long-term solution for people with musculoskeletal and in my area of interest, spine-related pain, is to basically just fundamentally, empirically learn what it means to move biomechanically proficiently, expressing your activities of daily living through the characteristics of what defines functional movement. And your joints just get healthier and your capacity just gets higher, stability improves, and you can ditch the drugs. Okay, hope that makes sense. Went on a couple of tangents there, but all the best. See you next time.